today Commander Jennifer Reed from the Houston Police Department and Chief Executive Officer Wayne Young of the Harris Center for Mental Health. The reason why I speak not only to their titles but their organizations is the mere fact that the collaboration with the multidisciplinary approach is already a constant for their organization, for their jurisdiction, for their community. And again, knowing that we're here to share not only the challenges that we'll talk about and that help develop the scope and the services that were developed, but then the lessons learned, that is what we will then focus on. So what I'm going to hope for is that we not only have both of the, I was going to say contestants, so see where my head is, both of the panelists introduce themselves, speak to the organization in general, and then I'll have a couple of questions that we'll throw at you. So, Commander, if you don't mind.
So, Jennifer Reed, I'm the commander of the Houston Police Department Mental Health Division. A little background on myself. I have a bachelor's in education, master's in criminology. I've been with the Houston Police Department about 17 years, of which I've had a variety of positions everywhere from patrol, digital forensics, vehicular crimes. A little more on the business side, I've worked in the Offices of Planning and Data Governance. As a commander, I've been over risk management, which is policy, as well as internal audits. I've been over Midwest Patrol, and I'm now over the Mental Health Division as commander there. And it's a division like no other. It's amazing, some of the people that I work with and what they do and the passion they have with their position. And we have a really wonderful collaboration with the Harris Center. So I'm very happy that we have Wayne Young here to join us today, because it truly is a deep collaboration that goes back with predecessors of both of us. And it is a strong bond of leadership in which from the top down we show that collaboration is very, very important with the local mental health authority and the Houston Police Department. So, Wayne.
Thank you. Thank you, Jennifer. So my name is Wayne Young. I'm the CEO of the Harris Center for Mental Health and IDD. So for context, that's known as a lot of different things in a lot of different communities. Community Mental Health Center, Local Mental Health Board, Local Mental Health Authority. The quick shortcut answer is we are the public mental health system for Harris County and our nearly 5 million residents that live in our community. There are 39 community mental health centers across Texas. We are one of those 39 and obviously the biggest one. From a scale standpoint, we have 2,700 employees in our mental health and IDD division. Last year we served a little over 90,000 unique people across our community. A big chunk of that, we also deliver the mental health services in the jail. And so there's a fairly large percentage of those came through that door, if you will, to our system. We have 4 divisions. We have a regular outpatient, we have an IDD division, a crisis service, and a forensic division. And so that crisis and forensic floats back and forth a little bit across some of the things that we'll be talking about today. But we share that commitment to partnership. You'll hear us talk a lot about that. It is hard to find one of us talking about this work without the other one, because you really do miss part of the perspective if only one of us kind of shares our approach and how we go about doing this work. So I'm glad to be invited here today and to share a little bit about the work that we are doing.
Wonderful. Thank you. So tell us why it is important to have this partnership. I mean, some of it may be obvious, but again, we've made reference to what is the culture shift and the change management issues. Besides the sort of resource-intensive nature, the change process within different jurisdictions that may dabble in this thought and figure out, what are the benefits? Why is it critical? What is the business case? And why is it critical that you both be responding to these efforts and supporting this community in this manner?
So it really is a call of where it takes so much to help people out in the communities now. And you have to have that partnership, because there's some responses the police department can do, and the police department is called more and more to solve and to help individuals in cases where there really is no crime committed. So in these cases, you have where officers can help in some ways and de-escalate, but there's the second half of that to help close the gap and to actually get people to resources where you have to interact regularly with the behavioral health specialists to really bridge that gap. The way that you see it as with law enforcement is sometimes I've seen with other agencies, they want to always consistently take the lead, and you truly need to look at it as a partnership. and to see what the police can do. There's some cases that we can EDO someone, we can take them in for an evaluation. There's other things that the behavioral health specialist can do. They can look up with hospital systems, with Epic records, and they can actually look and see where there's beds available to take people that are in crisis. Law enforcement can't do that. So there's a need in each avenue for both to work as one to truly help out with many things within our communities. To be really effective with these responsives, one of the things that we've done with the Houston Police Department is we have our crisis call diversion, where we have crisis call counselors that are embedded in our 911 call taker facility. So starting in about 2015, we started this program with the Houston Police Department, and the call comes in to 911 with the call taker. It's coded in CAD, and then it's moved to where it goes to HPD dispatcher or Houston Fire dispatcher. Sometimes it's a dual response, sometimes it's a singular response. It's there that the crisis counselors can look for 27 different codes that may have a crisis nexus to them to see what the best response would be. The mission of these crisis call counselors is they are looking to assist first responders and the persons in need of care, and trying to respond with empathy, connection, and linkage to the right size care. So that's saying of how we're going to respond. If we're going to send civilian units out, if no crime has been committed, are we sending law enforcement out there if a crime has been committed, even though we know someone is in crisis, that there's that layer, and kind of bridge some gaps along the way. They can do safety plans, they can do assessments over the phone while law enforcement sometimes is en route. And just key to linkage resources sometimes, and sometimes there's cases where law enforcement doesn't need to respond at all. So that's one way that we've tried to be efficient right from the get-go at the first intercept with our crisis call diversion center.
And if I can, I'll add, because I think the spirit of your question was around the collaborative nature, and I'll share. Commander probably won't, just because of the humility of the department, but part of it not only is the obvious clinical difference or training difference, but it is how to navigate the system. So when we first had this idea, we showed up at the 911 Houston Emergency Center and said, hey, this is our idea. And frankly, they said, no, thank you. We got it covered. And what normally a mental health agency would do, and what we did in that conversation is, okay, we think it's a good idea. If you change your mind, let us know. But Commander's predecessor said, no, we're going to do this. This needs to happen. Since then, obviously, we have diverted thousands of calls. Literally thousands of calls have gone not requiring a law enforcement response or answer. And then even in that moment, so that leader had enough authority to push the issue, and we were in there. But the first day we're there, the EMS folks say, "No, we're good. We don't know what this is. We don't know who y'all are. No, thank you." It was about 5 months in when they kind of peeked their head around the corner and said, I hear y'all aren't going to thousands of calls. And we said, yeah, it's working pretty well. They're like, well, maybe we could do that, right? So it's that entrance into that environment. It's that partnership and them having a credible voice in that conversation that we would never have had. To say, no is not the answer. We're going to get to yes, and them advocating and driving that change that led to literally so many fewer people engaging with law enforcement or EMS when they didn't need to. And frankly, it saves the EMS side a lot more money than it even saves the police department because of the cost of their responses and the avoidance of those responses. So,
and how many years ago was that? Did you say 7?
2015, I believe, is when they initially started it. Due to, there's a little thread I'm hearing about reform and funding. So Human Health Department is about half the funding, as well as our local mental health authority, which is the Harris Center. But due to ARPA funding and some reform, we've actually been able to push that service where it's 24 hours a day. Over the last year, we moved towards that.
Excellent.
But prior to that, there was some gaps in time where there was the least amount of calls where it was not 24 hours a day.
And our friends here in Austin, I was in a meeting with them today on the 988. If you haven't heard about 988, we'll talk about it another time. But they think they were the first ones. They were not. They came afterwards. We were the first 911
healthy
center.
Competition is always good.
Was embedded mental health clinicians in the 911 center. It was in Houston, not even Harris County. We've got several others in Harris County we're not involved with. But
So for any program dealing with the sort of 7-year program, on the one hand, 7 years ago, that was already a change management issues. How did the officers in this instance deal with the change, with the partnership, and how does the training that I'm sure you have in place then support the provision of services so that they are at a comfort level and a partnership level with Wayne's group?
Well, our department as a whole, since 2007, we've required CIT training for all of our officers. So there's a base level of training, but anytime we have this collaboration, specifically in the mental health division, we go all in as far as we're invested into the partnership. I mean, even as when new officers come in within our division, or new hires, or someone who's a lateral within their agency, we both sit on each other's panels. So there's a strong sense of collaboration, and as these new programs come about, it's just giving the officer one more tool to handle tough situations on a variety of calls we're being called to. So, and helping, it's in cost avoidance by some of these calls and we're having to go to before, and sat on the board for a very long time in some instances where no crime was occurred, and eventually we got out there, that some of these we didn't have to go to. So I think it was a win-win situation. And then it's getting, with community, the resources they actually need. Sometimes people don't know who to call, so who are they calling? They're calling the police department for everything. And we do our best, as every agency does, into answering those concerns and triaging on response times and what we hit first.
And I'm assuming that from an evaluation perspective, and I certainly don't mean a formal one, but from an evaluation or metrics perspective, the numbers are showing great value to the community?
Yes, they are. They're certainly, we've also added some programs since it came about, one of which I think we're going to speak of in a few moments. So we've added more tools to the toolbox in with different programs, with different acronyms that can be responded to for finding that right-sized care. So I think in a minute or at some point they were going to show a QR code for both of our departments. And with that, you'll see a direct linkage to all the acronyms that we're kind of speaking on some of the programs. So if you had some questions, you can get some historical data as well as more explanation on all of the programs. And then there's so many programs with the Harris Center that if you look under their crisis coordination tab, that you'll see the parallels between our agencies on how they come together. But certainly from a metric standpoint, we're only scratching the surface. We could actually do much more if we're able to expand. But
Agreed.
Certainly there's been a cost benefit as well as a benefit qualitatively to those that are being helped on the other side of the call.
Absolutely. And Wayne, from your side of the house, how's the process supported? Is there technology involved? Is there protocols involved? Obviously, coming from the mental health perspective, you're coming in with the SME expertise, but how are you sharing these things to begin with?
Yeah, so I think the commander's point about the training is crucial. Really, most of our collaborations when we started 20 plus years ago started with cross-organizational training. And if you took everything away, and you'll hear about and read about some really cool stuff that we do, but if you said you could only keep one thing, the thing I would keep is that training and joint education component. I had an opportunity with the Council on State Governments to do a presentation just on all the different trainings we do. Interdepartmental, interagency, intra-agency, interjurisdictional. It really is powerful, the impact that has when you begin to understand the thinking and the culture of other organizations. And so for us, and what I talk about with my mental health colleagues is, we've spent a long time talking about, hey, we want to be partners, we want to be, kind of joint in this work, but then we only really honestly often come to the table really focused on our goals, right? And our goals are around mental health and wellness and recovery and, reduce symptomology and those kind of things. And so if you show up at this table, you have to be willing to prioritize your partner's goals too. You have to be willing to think about, this may be success for me, but what does success for them look like? And often those are different, but not misaligned. They're just differently focused.
And are there any programs coming from your side of the house or that you are collaboratively working on that show individuals that need the mental health services but may not be a life-threatening one? And I mean, they're not in full-out crisis, but they are support services that then are provided to the community that, again, provides qualitative value that is hard to define and is hard to measure.
Sure. We have over 1.1 million calls that we get in a year through our 911 dispatch. About 46,000 of those, and every year it's increasing, have a CIT nexus. So one of the acronyms of one of the things that we have, and one of our core collaboration efforts that started in 2008 is our CERT units, which is master level clinician along with an officer who can respond citywide to different scenes. And that's where we can offer immediate resources with that clinician right there on the scene with the officer to help make sure it's safe. And they go from every type of call where there is no crime to those that are all the way up to possibly a SWAT scene, where it could be very beneficial to have a clinician on the scene to get any kind of record access of any triggers or any past history of someone who's on that scene to help de-escalate it as quickly as possible in the safest manner. So there's those CERT units are definitely very helpful in providing those resources and immediately knowing how to link the individual and assess quickly with the right service that they need to be associated with.
I'd also add, so that program, I think, it's one of the kind of foundational elements of our cooperation and collaboration. But as you can hear, and place I was talking to earlier has the same kind of recognition, is that you end up with a relatively small number of calls you can go on, right? Houston's a big place, lots of traffic, lots of things going on. And so one of the things we began to look at is how might we create access to that mental health expertise on a more affordable way, right? On a larger scale. That relationship is one officer and one mental health clinician. And so one of our colleagues back in Harris County came up with the idea of using technology to leverage the behavioral health expertise. We refer to the program as CORE, Clinician and Officer Remote Evaluation. And so essentially, we've got today in our community, we have about 350 tablets deployed across 12 law enforcement agencies and an EMS service. The largest number of those tablets are with HPD. They're about a third of those. And those tablets are in officers' patrol cars. They get dispatched on a call. They get there and discover that there's a significant mental health component to what's going on. They can pull that tablet out. They literally hit one button, and that client connects to one of my crisis mental health clinicians in a HIPAA-compliant telehealth platform that we use to provide immediate crisis assessment. Assessment, if you're a clinician, assessment means like an hour-long thing, right? That's not what I'm, perhaps crisis screening, crisis triage might be a better framing for it. But we kind of immediately, I've got this wonderful picture. We didn't do slides because we didn't want to distract from the message, but there's this tremendously powerful picture of a gentleman. We're in Texas, just as a reminder. If you haven't gone outside yet today, you'll be reminded. But there's this incredible picture of this gentleman sitting on the bed of a pickup truck, holding a tablet, kind of midday. You can see in the background he's in a parking lot of a strip shopping center, and he's getting a mental health crisis assessment right there. And what we're really trying to do is trying to help. We're trying to de-escalate, and we're also trying to help that officer with what is the right clinical outcome. Do they need to go to the hospital? Can we send our mobile crisis team out there? Is this already a client of ours, and we know him, and we can have a case manager meet him at his home? There's another great picture of an adolescent sitting in their bedroom, typical messy bedroom, right? You can kind of tell it's probably a little chaotic in the house, and we're doing another crisis assessment there. And so we did do an evaluation with the University of Houston on that program, and all of the feedback came back most positive around officers' perception of the support, the reduction in time. What would they have done if they hadn't had us? In most cases, they would have taken that individual to the emergency room, which could result in hours of unneeded care for the patient and perhaps wait time for the officer. And at the end of the day, when they had that tablet, I think it was the pilot that we had done was several hundred people. I think 2 people had been taken into custody when they responded and used those tablets. So it was a great tool to help kind of further that decriminalization of mental illness and kind of that path and process.
That is extraordinary. Were you going to say something?
Yeah, so in speaking with reform and some of the expansions we've had, so we had CCD expand with dispatch. Our CERT expanded by 6 units, so we're up to 18 citywide. A new program was the CORE, which we just talked about, the telehealth, but additionally we have the MCOT rapid response for these calls that it's actually 2 civilians, one is master level, one is not, that can respond to scenes now. That's a new program with the Harris Center this past year.
And so a little bit about that. So those mobile crisis we have two kinds. We have a mobile crisis teams and we have mobile crisis rapid response. And the difference is those rapid response teams are dedicated to being dispatched in response to 911 calls where there's not really a crime. And so you heard that expansion of the embedded mental health clinicians in the 911 center. So they pull those calls out of queue, certain coded ones, try and de-escalate them. Many times they de-escalate it right there on the phone. There's not a need for anybody to go out. And occasionally they'll need to put it back in queue for dispatch because it's decided somebody's got to go, and it probably needs to be EMS or law enforcement. But if they need somebody to go and that isn't required, then they can dispatch our mobile crisis rapid response teams. And so these are non-law enforcement teams that get sent out to respond to mental health, substance use disorder, sometimes social servicey kinds of things. We're not overly rigid about what a mental health call might mean, right? We're not trying to meet some technical definition of that. That's 24/7. We have, I think, 20 teams of those that go out in response. So trying to, again, find a way, as you hear me talk about it, it's with respect and appreciation, not negative, but trying to find ways to reduce the footprint of the criminal justice system in the lives of people with mental illness. That's my goal in these programs. Not because they don't do a good job, they are tremendous partners, but they're pretty busy, right? They got a lot going on, and Houston's a big city, and there's a lot of things that need their time and attention. And often, folks in mental health crisis can be better served with alternative response. And so that crisis outreach team response is a nice way to engage those individuals. We have radios. We can still connect with law enforcement. We can still get law enforcement brought to the scene if need to be and use their approach and their tools to try and help manage a crisis if it's beyond what we can do. One little caveat, and it's challenging, and HPD has tried a couple of times to change it. In Texas, only a judge and law enforcement can initiate emergency detention. So you can have me there all day long, but if at some point they need to go to the hospital and they're not willing to go, we have to involve law enforcement. It's unfortunate. I think most of us would like to see that different, but today that's the case. It did last 2 sessions ago, it made it out, but it didn't get signed by the governor. So there are times, even when we know what the right outcome is and what needs to happen, where law enforcement will still have to become involved in that. But it's much different if it's because, hey, we know this is the outcome that's needed, this is the risk that they're demonstrating, and it becomes a function of their authority and using that to get them into the involuntary status.
So there's still refinements that have to be made, which is of course predictable. But the change process that you've gone through over the 7 years, I'm sure has been iterative and progressive, and frankly is very impressive. Speaking to what was the traditional approach probably 8 years ago, it was a criminal justice response, right? And the individuals is in distress. They may have created or acted in a criminal manner, and then the only response is incarceration, whether that's short or long term. How have you seen a difference with the engagement of the traditional model, or then the reduction of the traditional model engagement with this program, and what are the long-term benefits that you've been able to witness, whether for the individual or the systems, respectively?
You want to go for it?
So there's other programs that we have that we've brought about, like the Diversion Center. There's many diversion centers across the country, but we've had one for, last 5 years? They've been there. And what we've seen is those that are doing lower crimes for misdemeanors, primarily criminal trespass, that we would take them to the Diversion Center, which is a Harris Center facility in which the charges are not accepted by the district attorney, so there's no criminal charge there. They're immediately put with linkage and planting that seed of hope of trying to get to the root causes and trying to get that person the right mental health to where they'll stay out of the system, whether it be criminal justice or in the healthcare system or wherever it may be. So these diversion programs seem to have been very effective within our jurisdiction, that they played a big role in helping reduce some of our misdemeanors. And it's also reducing recidivism, but it's helping place them to where for lower level crimes, they're getting that long-term mental health care of what they're really needing.
And I think I'll add to it. So, as we, and trying to kind of organize it for everybody's thinking, I think of it in terms of co-responder, virtual response, and non-law enforcement response, right? Like that's kind of that first piece. And one of the things, and we have been doing co-response for many, many years. That goes back well before the last 8 years. It's probably close to 15 now, maybe even a little longer. And often the conversation was, we are happy to divert. We're happy not to take people to jail. Where do you want us to take them, right? That became the logical question. And so our answer in our community became a diversion center. It's a pre-charged diversion center. Law enforcement drops off there in lieu of jail. It's voluntary. So if they need that involuntary level of care, that's a different setting. We do have a psychiatric emergency service where they can drop people off involuntarily, where it's secure and all that, as a result of a mental health crisis. Now, these calls often do start with a minor criminal offense, right? So these are all misdemeanor, and not all misdemeanors are eligible for diversion in our community. It is often a conversation between the officer and the DA's office in terms of should it be diverted. They work that out. They've been kind to occasionally to ask our general input, but we recognize we don't have the kind of public safety responsibility that they have. And so my position is when somebody shows up, our response is right this way. We're not getting into should they be or should they be. The decision's been made, and our role is to support them through that diversion. That diversion is 24/7 drop-off, misdemeanors, primarily Class B. We will take Class Cs, although that wasn't the target because most of those are ticketable offenses. But if they show up, what that usually means if they show up on a Class C is an officer knows them and knows they need help, and they're just trying to get them someplace, right? Because they could have dispositioned that and not really been too burdened by it. The drop-off period is less than 8 minutes. So the time they walk in the door to the time that they are ready to leave. Sometimes they hang around for a few extra minutes because the coffee's good or whatever, but from the time they're ready to leave is less than 8 minutes. That's our commitment to them. And talking about the impact, so we have done plenty of outcome evaluations. Justice System Partners has done the two most recent ones. And what we found is that for those that were diverted, they compared them statistically to a like group and found that if they, across the board, they were 1.5 times less likely to be booked into jail on a new charge in the year after diversion compared to the group who didn't get diverted at all. And part of our conversation in the community, and part of it was even with Commander Reed's predecessor, was, well, what about the people who've been arrested a lot, right? And that seemed like a fair question. I think all of our assumption was if you've got significant involvement, prior involvement with the criminal justice system, maybe the diversion isn't so impactful. So we talked a little bit about us, and we'll do the data again. Paid partner to go back and revisit it. And the first conversation was, well, what is a lot? And honestly, there wasn't agreement on what a lot meant. And so I made up what a lot was. 5 times seemed like a lot to me, right? So that's our standard. We're transparent about how we got to 5. If I had it to do over, I'd define it at 3 because 3 is the average number of bookings for people in the Harris County Jail. We had another review that we did on disparities in the jail and disproportionality in the jail, but 3 would be what I'd pick today, but we picked 5. And what we found is that if you've been arrested 5 or more times and you got diverted, the impact, the reduced likelihood of rebooking almost doubled. You were 3.1 times less likely to be booked into jail on a new charge if you had been arrested multiple times. I can't fully explain that dynamic, but that's the presence. Also, what we found is that we reduced the frequency of psychiatric events, emergency psychiatric events, by nearly half for those that got diverted. And then, some of us are driven by different things. Some of us want less criminal justice involvement. Some want mental health wellness. There are some who care about the money part of that equation. And so what we found is that for every dollar we spent on diversion, we avoided $5.54 in criminal justice cost. That includes the jail, that includes the jailers, that includes the food, that includes the DA, the public defender's office, the court's time, but no social costs. Nothing to do with me, nothing to do with the rest of the community impact. But that's a pretty substantial return on diversion for low-level misdemeanor charges, right? In fact, the primary charge you will see was trespassing, criminal trespass. Originally, when we started, it was only criminal trespass. Frankly, that was strategy. It wasn't. No one was arguing that homeless people with a mental illness should go to jail, right? That wasn't a big argument in our community. And so it was a safe spot to land, and who are we going to divert? So we all came together, the leads in Harris County Sheriff's Office and HPD, the DA's office, our county elected officials, and myself, and said, okay, let's start with trespassing because nobody's going to argue about it. And then about 6 months in, we opened it up. We never did define what was divertible. What instead we defined is what was not divertible. And then everything else is on the table for discussion, right, on a case-by-case basis. You will see, if you went and looked, there are still multiple people every day that get arrested on trespassing, and probably appropriately so. I don't question that. It's not my place to. And so it really does become a case-by-case kind of conversation and decision-making. Initially, when it started, 95% of the diversions were driven by the DA's office, meaning they said, no, we're not going to do charges, take them to the diversion center. This month, I looked it up before I came because I had my monthly report we share with our stakeholders. A little over half of our diversions are law enforcement driven, meaning they never even called the DA intake line to talk about whether they wanted to divert. They just brought them to us on their own, recognizing, A, that's probably what was going to happen anyway, is my guess, but B, that they're going to probably get more help and support through us. The other nice advantage is with PR bonds. On a misdemeanor charge, they're going to be in and out of jail in less than 12 hours in most cases, right? Their average stay with me this month was 113 hours. So even if the officer's goal is, I just don't want to see them, right? I don't want to see them back on this corner. I don't want to see them back while I'm on duty. There's a better chance they won't see them if they bring them to me than if they were to take them to jail.
And to make one comment about the criminal trespass, the ones that we do keep, you're looking at critical infrastructures, airports. There are cases in which you need to have that as appropriate charge, if not something higher, and something that can stack eventually to felonies, if need be, for certain instances for individuals we know are a true safety issue.
Of course. All right, so obviously from a program perspective, this is absolutely one to model the success, right? I'm sure that there were challenges along the way, but all that I'm hearing is you addressed and succeeded with the changing of the culture, with the partnership, with the mindset, with the community awareness. You've, of course, succeeded brilliantly at the partnership issues, the operational outcomes. The only two things that are coming to mind, and it's really more of a question, is do you feel that there would be better or more opportunities that should be addressed with regard to evaluation so you have those performance metrics? And I don't mean people getting into your space so that then they start changing and making suggestions, but if even just the provision of the data and your numbers so that people could slice and dice it and say, look how effective it is. Look what that extrapolation would be as in the dollar savings to the CJ system versus what is doing not only a financial savings, but an enhanced quality of life. And then the other one was, do you have replication guidance? And I say that if there's another agency or another jurisdiction out here besides Houston and Austin that we know have programs in place, is there guidance in place that other than your own documents that then might be helpful to you? I know we didn't chat about that, but I'm figuring you're good.
Absolutely. So I'll talk a little bit about the documents, and then probably Commander will want to talk a little bit about some of the site stuff that we do, the learning piece. But so the answer to that is, of course, yes and no. So the tablet program, we started that in partnership with Harris County Sheriff's Office. There is a replication guide, an actual guide. It's a nice document that's out there. It's on their website. We've got it on ours. Also, that link will take you to our main website. If you go to HC Intercept, if you're familiar with the sequential intercept map, it breaks up the different kind of phases of as people progress through law enforcement involvement or criminal justice system involvement. And at each one of those is called an intercept point, and then we have mental health best practices to try and intervene or facilitate through the process, and you'll see these programs and they're there. So the tablet program absolutely has one. The Diversion Center, we also created a replication guide that lives on our site. The number of visitors and calls is phenomenal with all the programs. There's a Diversion Center being built in Atlanta. There's one in Dallas, there's one in Fort Worth, there's one in Austin that's being built, there's one in Lubbock that's being built right now. So there's a fair amount of replication that's happening. Of course, each community makes it their own. So we don't make it, overly specific. But we talk about the process we went through to try and bring that to fruition. We also share all of our outcome studies and evaluations, so all that's available. And HPD does a really nice job on their website, putting a lot of the statistics and outcomes as a part of their website. And I will also say, when we came together on the Diversion Center, we created subgroups, work groups, if you will, and one of them was around data. And we brought the stakeholders to the table because, to my point earlier, we have different outcomes, right? One of the things that HPD wanted to know is how many times do we touch them less? Do we come in contact? Right. I would have never thought of that. It's not a measure I would have ever even thought about looking at. And the sheriff's office wanted to know, do they go to jail? But that wasn't the question HPD had. They didn't necessarily, that's probably important to them, but that wasn't their number one thing they wanted to know. And for me, I wouldn't have thought about either one of those. So thinking about the data on the front end, I didn't mention we've also, 4 weeks ago, we opened a youth diversion center targeted at youth committing a crime of assault to a family member, and keeping them out of juvenile detention and bringing them to a mental health crisis unit. And we did the same thing with them. That's brand new, but we sat down with our partners and said, what do we want to look at in terms of outcome and impact with this? So that's the answer to that part. And we're happy to share those if they're not, if you have a hard time finding them, we can get that information to you.
Thank you.
You want to talk about the other piece of that?
Sure. So the Harris Center does a phenomenal job, and they clearly have more personnel to do the data analysis and to pull things together for the success of the program and truly being able to implement in other areas. With HPD and with the Harris Center, one part that we have in educating other agencies, even internationally, is we're a BGA learning site. So for over 10 years now, we've been one of the original 6 that across the country, internationally, you can come visit our department and you'll see Harris Center employees as well as ours with HPD, and you can get a look at all of the list of acronyms on how these programs are truly being implemented into our department and seeing how it can fit in other agencies. And you're looking at some qualitative and quantitative results. You're looking at cost savings and cost avoidance. But it also helps get an intimate view of what's needed in certain areas. Some of the things I've seen over the years with challenges that I'm seeing with other programs being implemented across the country is they're very siloed. So they get funding and there's competition for different grants or different contracts, and there's not a lot of information sharing, which is inefficient. So we're very lucky in Houston to have the Harris Center that really helps the continuity of care. You know, we spoke on earlier on these different programs of we know if we've handled someone before or not, or if they're a new transient to the area or whatever it may be. So that seems to be a great challenge across the country, as well as grasping EMTALA. With the turnover in the police departments, turnover in behavioral specialists and in hospitals, seeing how that plays a role with data and with understanding of the laws of there is not a such thing as a psych diversion anywhere in this country. That if someone is in need of care and they're a hospital, emergency room, they have to take the individuals. And professionally, both sides need to explain to each other as there's turnover in personnel on how that needs to be smoothed over to that, so that those in the community get care that are consumers in crisis. So certain challenges with the law, if you knowing EMTALA, knowing that you can visit other sites with BGA, and then just asking the right questions of agencies to where not everything is, redeveloping the wheel. I mean, there's programs that are very successful out there, and it's just finding what fits with the funding and with different jurisdictions the way they mirror. You know, some have EMS with behavior specialists. That's not the case in our area, but that is a program that's out there as well.
All right. There are different flavors of a fundamental response. So I do have other questions, but I want to open it up and try to keep to the schedule. Are there questions that the audience has of our panelists? Every time I say, okay, we have no questions, then somebody raises their hand. So I'm going to stare at you for a little while and make sure there's nothing coming. All right, so then let me ask you, if there's no other questions from them, should I say something, or should I just let the pregnant pause go and say it for itself?
So the relationship between the individuals you encounter, the diversion tactics, and any kind of enrollment in like mixed indices for mental health purposes, is it your teams that maintain that connection for the experience and background check purposes?
So a lot of that is driven by just reports on whether we're doing reports or how often we're running them. We do keep some internal databases on who we've handled as well as the Harris Center, but it just depends, because even with our mental health division, we're only scratching a portion of them. I mean, I only have 18 teams citywide. We have 3 investigators that look through these 46,000 reports a year and try to make sure people are being connected with the right services at the right time and making sure data is getting transferred efficiently. So a lot of that's going to come with our report system, just with our normal entry with our RMS system. Is where a lot of that's going to come. If not, it's going to just be with the EPIC system and some of the systems that Harris Center has that ensure that continuity of care and the longevity between services.
Trying to keep some of these people away from firearms, even for a period of time, like in the form of a red flag or an extreme risk protection order, or even mix indices into entry if the person was professionally educated as
So I'll add to that around the firearm piece. First, it's Texas, so we don't really believe in keeping people away from firearms, but that's a different conversation. And so there are databases that psychiatric hospitals can report to once a person's been involuntarily committed. So the emergency detention doesn't do it. That emergency hold doesn't do it. There is a mechanism in which firearms can be removed in that emergency hold period. It's kind of immediate on scene kind of thing. The firearms can be taken until they're released from the hospital.
But then they're given back.
Yeah, but in the inpatient psychiatric hospital side, there is a reporting mechanism at a state level where psychiatric hospitals, it's a can, not a shall. The hospitals I've always been affiliated with did. Part of that's because for the last 15 years I've worked in safety net systems and I was administrator of 2 inpatient psychiatric hospitals. And if you're at that level of acuity and illness, you kind of feel a sense of responsibility to do all you can as the hospital side of that equation to limit access to very significant means of harm. And frankly, even not necessarily externally oriented violence, but a lot of the people that we serve die from suicide. And the most lethal means of suicide is a firearm. And so we do a lot of work trying to create a discussion around firearm safety that doesn't have anything to do with the politics of guns, but has to do with safety and protection of those we serve.
And it's only the imminent. Sometimes there's scenes where, there's one gun that's taken, but there's multiple guns in the scene that we're not taking. So there's definitely challenges there and room for growth with time. But some of that is policy driven within our state. But maybe something different on a national level that can change.
And I will just add an aside that in Texas, our community mental health centers are units of government, right? So we've got all the same kind of public access stuff. Even a community mental health center cannot limit access to the building with someone with a firearm. If they want to bring a firearm into our clinic, they're allowed to legally, and we can't ask them about it or stop them from it. So there are some challenges. We don't have kind of fluid logic around all of that. We did. It took a special activity, but we did get them where you can't take them into state psychiatric hospitals now. But for a couple of years, you could take them into state psychiatric hospitals as well. So we're not really consistent and solid on our thinking through access to firearms for the population we serve right now.
Wonderful. Any other questions from the audience? Alrighty, then I guess the last question that I'll ask you, is there any way that the IDIS community can help? You weren't here when we had Ron Chapman from the COPS office say that serving as a voice to the community, to the practitioners, to the membership organizations, to the industry is certainly something that we would be more than willing to do. But is there something else that you can think of that the IDIS community can help?
I think it's just, looking at it at a national level since we are local and seeing some of the linkage issues that we talk about, that we've seen, some that we've been able to remedy in our area, but are still issues nationwide. And that data sharing is trying to improve upon that. And then one thing I do want to speak briefly on, if I have a moment, is we've titled this Community and Officer Wellness, but we spoke mainly on community, which officers are part of the community. But to kind of do the linkage of, when there are issues, it is a big issue across the nation right now with officer suicide. Officers have been through a lot with time, but especially within the last 5 years with COVID, with civil unrest, with different storms, other national disaster, staffing challenges. Just with the Houston Police Department, we have around 5,100 officers, but we're the same population that of Chicago when they have 14,000. Staffing issues, if there's any way to help improve efficiencies from individual standpoints to help with our staffing challenges that we have. And then just know with the officer aspect that if you are in contact or if you're in law enforcement yourself out in the audience, that some of the things that we have with Houston Police Department is another whole list of acronyms of services, from your psych services, your peer support, your HOPA with the union, Cortico app technology. but just understanding that there needs to be a lot of warm handoffs into programs so people don't fall through the cracks. There needs to be looking at national level, if IGES or anyone can help with our healthcare system, that those officers that are seeking help often have challenges with the copays. They can't afford the copays for a 30-day program because, frankly, they're too high. So there's a lot of challenges, and there are some programs out there with officers that they don't need to be taken to the same facilities of that they're taking themselves people to. So I just look under a spectrum as you kind of go in your parting ways, and I can't see and know where each of you are from to know your linkages on kind of what I'm seeing, but I know there's some of you that can help on what I'm saying, providing linkage and continuity of care and helping with some of our struggles with our community and with our officers.
And we will definitely have future conversations because there may be opportunities there.
I would add, I think even just this process, like creating a space to kind of normalize the conversation, right? And
Right.
to allow people to hear things that, I've been in other places where I hear something, I think, I never thought about that. Or I didn't even recognize the potential. And so normalizing the conversation, fostering, some innovative ideas. I will also just take 1 second to add just a moment. So we've talked about suicide. We've talked a lot about mental health. I do want to add substance use disorder to this conversation. I'm not going to start it back over and have all of the conversation again around substance use disorder, but it is in that bucket, right? And as much as we talk about suicide in our country, 988 is a great example of that. It's a 3-digit number. Anywhere in the country, you dial 988, you end up talking with somebody like one of my crisis counselors. If you're a third of the population of Texas and call from certain areas, you will talk to my people. We cover it for about third of the population, half the calls. But substance use disorder, so nationally and in Harris County, almost twice as many people die from overdose as die from suicide. And we don't talk nearly as much about that. I'm not sure why, but that is critical. And frankly, when you look at suicide and substance use disorder, it disproportionately impacts officers. They struggle with that at a disproportionate level. I suspect it has a lot to do with the trauma exposure and those kind of things. But I don't want to leave the conversation without at least adding the context of substance use disorder to both parts of that conversation for the room.
And I appreciate that. And I don't know that either one of you were here this morning when we were talking about the different summits that we have on the horizon for this calendar year. Substance use disorder is one of those specifically. So if that is of interest to you, we would love to have you as a member at that panel or those in that event. Help us develop the agenda and contribute to the outcome. So those things we can do well and easily. The funding issues, the policy changes, we can certainly investigate those things, research those things, and make those connections. But the first one's an easy one.
That's great.
So let's thank the panelists. We appreciate everything that you were able to provide us.